prepare for this, so I'm probably going to stick more to the handout to remind me of things that we need to cover. You don't have to acknowledge it, but if you've had migraines and you want to add into this, since it's a fairly common disorder, then please do. Please chime through. The majority of what we're going to talk about today are migraines. Tension headaches and cluster headaches, which are really an interesting headache type. Okay, so let's start with migraines. I think Dr. McNeil is going to talk about this afternoon, so I don't know how we got flipped, but we did. Okay, let's go through the different headaches. So migraine, if you're in primary care, you will see a lot of it. So it's the most common reason people will come to you for a headache and want to seek help. Or they'll come to get relieved from a migraine. So not an uncommon presentation. Tension type, most people, it's the most commonly occurring, most people will self-medicate. You will rarely see them in your practice, or more rarely. Cluster, very unusual type. It requires treatment. It is such an intense and awful headache that people will come to see you. It will always be an acute, so it may be more an ER or a urgent care situation. And then there's medication use headaches, which usually come out of the first two. So it's the overuse of medications to relieve headaches will actually make it worse. So we'll talk about that in each of these contexts. So I'm going to give you just some brief background with migraine. When I was in at your point, we thought migraines were due mostly to vasodilation, and we treated them mostly with vasoconstrictors. That is true, but it is not the whole story. So I will give you some of that this morning. I think Dr. McNeil will give you more of it. I'm not sure I understand all of it. It's more complex. So in just a brief epidemiology, women are going to be more than men in this complaint. The gender differences go across all age groups. Highest prevalence for migraines is in the 30 to 50-year-olds. It usually starts young. You can see it in kids, especially if their parents had it. It seems to be an inherited trait or disorder. Starts usually young, 12 to 15, and then will, and in young adults. But the highest prevalence is in that 30 to 50. Let's see. 93 reports some headache-related disability, so that means loss of time off work or school. Are usually most common because not only do you have the headache, but there are usually lingering effects for a day or two after they have a headache. 54% report being severely disabled or needing bed rest during an attack. And I think that's probably what a lot of people have in their mind with a migraine, because what do you think about with a migraine? What do people do?
Dark place.
Dark place, get away, so you want sound out of the way. Visual stimulation gone. Okay. So brief pathophysiology. So it is thought that the initial dysfunction is, and if you look over on page 3, there's a picture you may want to look at as we're talking about this. So it's considered to be a neurovascular disorder combination. Okay. So it leads to changes within the brain and outside the brain, and there's 4 phases. So there's a premonitory or premonition type of symptoms, the aura, which not all people have, headache, and then the post-stroke. So it's a cortical spreading depression. So my best understanding of this, and you can look on the next page at those 2 figures, is that there is a wave of depolarization that moves across the cortex. It's slow. I think I read where it's like it advances 3 millimeters per minute. So that's That's not a lot of space, but given that we don't have a lot of distance to cover, then that, I guess it's probably pretty fast from this brain size. And you see on that page one, or on page 3, 1 is where it's starting, and it ascends up over the cortex, and it goes down the tracks into that trigeminal nucleus. So the trigeminal system is involved in this. That's where the neuro part comes in. So that depolarization depolarizes that trigeminal nerve complex. That releases vasoactive substances, so you get vasodilation. It also releases inflammatory cytokines, which lead to then the headache. And a lot of the headache is originating from the dura. And those pain receptors that are on the, I don't know if they're actually on the blood vessels, but they're mostly that dura matter, and they are very, very sensitive. So that's kind of an introduction. I certainly won't test you off of that, but that gives you kind of an idea of how complex it is. Serotonin is one of the major neurotransmitters in this process. So you're going to see that serotonergic agents are going to be effective. So triptans, sumatriptan, probably one of the most common and been around the longest, Imitrex, is very effective. Some of the SSRIs, very effective. And then you can imagine also that analgesics, so like non-steroidals, are going to be effective in this for these patients, or aspirin as well. So drugs for acute, just to kind of, this is just in general because we're going to talk about these all more specifically. So the drugs for acute we use are usually vasoconstrictors. So those ergot alkaloids and the triptans are the initial abortive type of drugs that we're going to use. And you can see vascular, so the ergot alkaloids are vascular in their effects, and the triptans are the neuronal, the serotonin, so they tend to hit both of them. We never, ever use them together because they're too powerful in their vasoconstriction. You'll stroke somebody out, or you'll give them a heart attack. So they are used for prophylaxis. They're also used to treat, so they have both. The triptans are going to be much more user-friendly in abortive attacks and in treatment. The ergot alkaloids are used more in acute situations and for more severe. They just have too many side effects for widespread use. Okay, so we're going to repeat all of that again. So if you look at, and I'll let Dr. McNeil explain that picture on 4. That gives you that more of what's going on at the surface of the brain in the dura, and the inflammatory, that calcitonin gene-related peptide is also related to all the more inflammatory response that occurs in that area. So I'm mostly giving you little snippets. I'm not giving you a cohesive path of his because I can just tell you I don't know it well enough to do that. But it gives you some things to kind of look at in terms of why we use the drugs we do. So let's talk about clinical presentation. Premonitory symptoms, again, premonition symptoms can be for a period of time, a long period of time, either hours or days before onset. The neurologic symptoms, you all have already voiced these, so the photophobia, so the light, wanting to get away from light, sound, the phonophobia, difficulty concentrating, thinking. The psychological symptoms can be, you can imagine the irritability, fatigue, wears you out. Pain is fatiguing. Drowsiness, the restlessness, anxiety, depression. Autonomic, so often these folks will complain of diarrhea. That's very common, that goes along with migraines, but constipation, increased urination. Constitutional stiff neck, yawning, thirst, food cravings, anorexia, a hodgepodge there. So the aura can be from 5 to 20 minutes before the headache, usually is brief, so less than an hour, usually visual. So what do you know? What kinds of things usually are related to that photophobia or that aura that comes about.
Seeing lights and dots and
So lights and dots, you remember the name? Scotoma? So they will see flashing lights, bright, what other term did you use?
and just like dots, like spots in the field.
That are moving around
Yeah.
the field. Okay, very good. Anything else?
I would have loss of peripheral.
Sorry, my peripheral.
Loss of
Yeah,
peripheral
tunnel
vision.
vision.
Sometimes people have a smell. They smell things that aren't there, but it will bring that out. Okay, so do you have migraine with aura? Okay, Lauren, you have
I
migraine with
did
aura?
when I was probably like 5 or 6, and I haven't had them
Wow.
since then. It was weird. I had them for a while, and then left.
Jordan?
My vision gets really blurry one at first, and then kind of transcends back.
Uh-huh, and how long does that last?
I usually get the blurry vision probably 30 minutes before, and then I start getting nauseous, and then it's,
Wow, Kayla? Is it the same every time?
I'll, like the change of smell and the spotting lights, but it started off with the peripheral vision loss, and that's how I got diagnosed with it.
Wow, I bet
When
that
it
was
was so
scary the
complete,
first
yeah, it was
time.
very
Wow, did you think you were having a stroke or?
Yeah, I ended up having 2 CT scans because of it, because I was like, there's something.
Brain tumor or
Yeah.
something along that. Okay, anybody else? Mariah?
I get that as well, and I also get nauseous.
You don't get nauseous?
I do.
You do, okay. And how long does that start before the headache?
Well, I currently have one right now, so I'll let you know.
Oh, gosh. Okay, I'm sorry.
You're good.
You want to spill a little black, you want to throw a blanket over you? Who else? Someone out there? Dylan?
Yeah,
You
and
get them too?
I do, and they've intensified since I started PA school.
Oh, I'm sure they did, yeah, I'm sure they have. Do the lights bother you? I've heard that fluorescent lights are really bad, that they can set them off.
Like riding in a car.
Riding in a car does it. Wow. Maybe we get mood lighting. We can tell Dan we need can lights with a dial down here. Anybody else? Clinical symptoms, so pain is gradual in onset, peaks in intensity over minutes to hours, can last up to 3 days. Can occur anywhere on the face and the head, but usually the frontal temporal region. Headaches are usually unilateral. So if you look back to that page, on the second page with the migraines, you can see that unilateral depiction there, as opposed to like a sinus headache or a tension headache being all the way across the front. GI symptoms almost always present. Vomiting's pretty common. Sensory hyperacuity, we've talked about. Once the pain wanes, resolution phase characterized by feeling tired, exhausted, irritable, listless, impaired concentration, scalp tenderness. That is very common to what we will see with seizures. Same thing, is that it's kind of like it wears the brain out. And so those symptoms can last for a number of hours after seizure as well. Okay, so those of you who have migraines, do those clinical symptoms ring true? Yes? Jordan?
yes, definitely.
Yes?
Yeah, I usually end up going and hiding in a very dark room for about 4 or 5 hours.
Wow. Okay. Anybody else? Dylan, since you're our male representative in the migraine field, does that ring
Yeah,
true?
I can probably even attest to the familial thing too. My dad gets them so bad, he can't sleep at night because they're bad, and then he'll wake
Wow.
up midday, 2 o'clock or something, and they're persistent.
Oh, gosh. So how old was he when his started?
His set in later.
Okay, how about yours?
The first one I noticed was probably late in high school, but I was confused by it. I had no idea what it was.
Yeah. Okay. Mariah, when were you diagnosed?
My sophomore year at college.
Okay. And
I had my first one probably about 14, 15, but I was diagnosed like
Later.
27.
okay. Lauren, you had him young. Now, for a 5 or 6-year-old, that must have been really, pardon?
I was never diagnosed.
You were never diagnosed?
No.
Wow.
Because it was like such a short amount of time. They kind of came in. I mean, my mom knew they were migraines just because of the symptoms, and they
Your
leave
mom have
after. No.
You know, I found that really hard when Cameron was little. When kids complain of a headache, it takes, they have to be pretty old before they can verbalize that. So it's really odd when a child has those symptoms to try to get them to tell you what they're feeling. So I can't imagine with a 5 or 6 year old trying to.
I would just tell her like my vision, like it always start because I'd hold my hands out and I couldn't see my hands. So then we always knew that's when it was coming. So I'd be like, my peripheral vision's gone. And
Wow.
I'd get a headache and it would be gone.
So that goes along with that cortical depolarization. They think that people who don't have auras, that the spread of that depolarization just affects different parts of the brain, and so that aura is not there. So page 5, let's go through common migraine and migraine with aura. So they're two different. So common and then classic. So the classic is with the aura. But my understanding is that the aura is least common. From what you all say, it sounds like you all have those auras. Okay, so this is the International Headache Society's diagnostic criteria. So with the common, they've had at least 5 attacks. Seems kind of cruel, but I guess to figure it out. Headache duration, again, of up to 72 hours. Untreated or unsuccessfully treated. Headache has at least 2 of the following characteristics: the unilateral, pulsating quality, moderate to severe intensity, and aggravated by or avoidance of routine activity. Not sure what that means. I tried to look, but I didn't get any more description by that. During headache, 1 or more of the following: so nausea and vomiting, photophobia or phonophobia, and not attributed to another disorder. So somewhat of a rule-out diagnosis. Migraine with aura, at least 2 attacks. So I think that's why classic, it follows a pattern that's more recognizable. Typical aura, fully reversible, visual, sensory, it's speech symptoms, no motor weakness. Homonymous or bilateral visual symptoms, so the positive features, so it's odd how they refer to these. So positive, the way I read, the way they do this is it's the presence of, and negative are the absence of. So the positive features are the flickering light spots or lines, and the negative is a loss of vision. So that loss of peripheral vision you all described would go into that. Unilateral sensory symptoms. So positive features are pins and needles, presence of. Negative features is numbness, so lack of feeling. At least 1 of the following. 1 symptom develops gradually over a minimum of 5 minutes. Different symptoms occur in succession, or both. Each symptom lasts for at least 5 minutes and no longer than 60. Headache meeting criteria for migraine without aura begins during aura or within 60 minutes. Let me look back. I don't remember what I wrote in terms of the agenda. Okay, so I didn't write a specific objective for those, but I think you should have some idea about what it would be to diagnose. Now that may be something they hold you accountable for in ClinMed. I checked these for adults and children, they are the same for peds as well. Questions about those or comments? Okay, let's look at goals of therapy. So let's look at long-term and acute treatment goals. So long-term, you want to reduce the attack frequency, severity, disability that the person is experiencing. Reduce reliance on poorly tolerated, ineffective, or unwanted acute pharmacotherapy. Avoid acute headache medication escalation, because that usually leads to that overuse syndrome. Reduce headache-related distress and psychological symptoms. Educate and enable patients to manage their disease to increase their control over improved quality of life. So the goal is very much to avoid, to get the number of attacks down to as minimal as possible. Acute treatment goals: treat the attack rapidly and consistently without coming back. restore the patient's ability to function, minimize the use of backup or rescue medicines, talk about those in a minute, have minimal or no adverse effects, that's hard, be cost effective for overall management because the therapies are expensive. So the carrying and because they usually have several modalities they're using, and they can be expensive. Some of them have gone generic, and that may help. Non-pharmacologic measures, so staying hydrated, ice to the head, periods of sleep in dark, quiet rooms, avoidance of triggers. Behavioral treatment seems to be effective. The cognitive behavioral therapy, you're going to hear a lot about that in psych. It's used for a number of different psychological conditions. Anxiety, it's very good at. Treating sleep disorders, it's also very good at. So as an adjunct, it's probably helpful in this situation. Physical treatment, acupuncture, cervical manipulation, immobilization therapy, those are things people try. Realize that very few of those ever undergo any kind of big evaluation. So it's probably going to be more individual. Headache diary, you can download, there's lots of headache diaries. I think I may have posted one last year, and I'll look for that and post it again so you can see. They're helpful to help have people document when they're occurring. If they're not aware of triggers, it may help. Once triggers are identified, having patients avoid those factors consistently provoke migraine attacks. Okay, so those of you who have experience with migraines, talk to me about non-pharmacologic measures you use.
Sleep,
Sleep,
water.
water, helps.
Usually do a washcloth.
Washcloth over your face.
Put it over my face and just hide.
Okay, Caleb, anything? Okay. Do you change your life in any way that would avoid triggers?
I close my eyes in cars.
Okay, so that motion,
Yeah.
movement really sets it off. Interesting. Dylan? Anything?
Since I haven't technically been diagnosed with it, I still was trying to figure out what it was. I found out lately though that like I'll just down 2 bottles of water and I can't get rid of my aura, but the headache is less.
Huh, interesting. Okay, anybody else? Yes, so,
I was diagnosed when I was young, and they started me on medications, but to get off of it, like my doctor had me write every time I get a headache and
yeah,
blow a trigger, and mine's usually the sun, so like the sun and the car, so sitting in the front seat helps a lot.
really, what do you do about the sun?
I don't go outside that much. Like yesterday, it's like I'll feel it and I'll feel it coming, I'll be like, okay, I gotta get out of this side.
Wow.
And the rest of the day, I'll probably be sleeping because of it.
Wow. So you always Dylan sunglasses as soon as you walk out?
No, it's just extended periods of staying in the sun, and sometimes I won't get it right away, and I'll get it like as soon as I go home, but I know the sun is what usually triggers it, especially in the summertime.
Okay. Anybody else?
Usually get triggered by computer screens for a long period of time.
Yeah,
So it's kind of hard to avoid.
it is. I think school brings out lots of disorders. I didn't wear glasses. I did as a kid, but I went for long years without wearing them. And then when I went to graduate school, that was it. Killed my eyes. Okay, so general approach. If you'll look on page 13 and 14, from the book chapter, I adapted this algorithm. So let's walk through them, and then we'll go back and talk about the different drugs. So once you have a migraine diagnosis, trigger control, let me ask you this. Those of you who have been diagnosed, who did it? Was it a primary care? They sent you to neurology? Neurology?
Mine was after my brother, who had a tumor, so I went to his neurologist.
Ah, okay. Amy?
My husband has them really bad, but I think it was his primary care that diagnosed
Primary
it.
care. Dylan, you said not diagnosed. Who else? Sony? Who?
I think mine was a psychiatrist, actually.
Okay. Neurologists are not uncommon. I have really bad tension headaches, so I went to a neurologist for a different reason. And he asked me how many, I don't know what I guess he asked me about headaches. And So he asked me what I used, I told him, and he said, well, how much, what do you buy? When you buy a bottle, what do you buy? I go, I buy 500. He goes, and I said, and I carry them in my purse, and he said, you know, that's not normal, but it's been normal for me all my life. So, interesting things you kind of get used to. I've had headaches since I was 10 years old. I probably have them every day. So I don't think they ever got to migraine accepted a few times, but anyway. So trigger control and adoption of a healthy lifestyle program. Assess the headache severity and degree of associated disability. And so that's going to drive whether you need to prophylax them. So prophylaxis, we're going to put them on daily medicine. Otherwise, we'll just treat the attacks. If they're few and far between, then it's easy to do that. So that is what weighs into prophylactic. You can pre-treat them with antiemetics if they have consistently nausea or once a attack starts and they come to your office, then using an antiemetic is helpful. And we have a wide variety, so you can use oral if needed, or you can use any of the other routes. IV, rectal, some are, you've got dissolving tablets that can go in the mouth, so they don't have to swallow. So mild to moderate analgesics, so acetaminophen, probably not as by itself very effective. Non-steroidals, aspirin, very effective. Ibuprofen, naproxen, those have the most kind of experience behind them. Combination analgesics, I don't know how much people use these anymore, but used to be very popular, called APC, aspirin, phenacetin, an old word for acetaminophen, and caffeine. That combination is pretty effective.
Isn't that Excedrin?
Yeah.
Does this, I don't know, Excedrin migraine you mean?
Yeah.
Okay, yep, all right, so it's under a different name. It used to be just APC. I think you can still find it generically like that too. Triptans, or medication combination plus rescue therapy. For severe symptoms, we go with the ergotamines initially and then move them over, and once you can get them under control. Would not like to use those forever. Next page, prophylactic migraine therapy indicated. So if you look at this, it gives you different comorbidities that are present, and then if the drug is, which drug would be most effective. But the other thing you see going down the right side is if the first step is ineffective, what you go to next. So it's a dual way to get to each drug. Okay, so if they have a predictable pattern of headache recurrence, then a non-steroidal or a triptan when symptoms are most likely to occur. So if you knew that every time you're going to be in prolonged sunlight, you could do a prophylaxis or an abortive. For healthy or comorbid hypertension or angina, then we can use beta blockers. Beta blockers have been used forever, a very long time, for prophylaxis of migraines. Propranolol, probably the most common, most well-known. So you can see also if your non-steroids or triptans didn't work under your predictable pattern, then a beta blocker is the next way to go. Comorbid depression or insomnia, then using tricyclic antidepressants, amitriptyline, long-term use. One of you saw somebody at Good Shepherd who was on Elavil for migraine. There was a young woman, amitriptyline. Or venlafaxine, it's an SSRI. Comorbid seizure disorder or bipolar, you can use an anticonvulsant. Topiramate is an anticonvulsant, we'll talk about it. They can be used, or a beta blocker, verapamil. Other agents ineffective, then consider combination therapy and a specialist if needed. Okay, all right, so let's go back. Middle of page 6 then. So drug therapy is the mainstay of therapy. So we've left surgery, behind in it seemed like everything that had happened was a surgery indication. Management may be acute, so medications to treat symptoms, abortive drugs. We will classify them as migraine-specific and migraine non-specific. So migraine-specific are ergotamines and triptans, vasoconstrictors, remember. Migraine non-specific are analgesics. Well, you know that we can use it for almost anything. The triptans have a very narrow indication. Ergotamines, very narrow. We use them when we need a vasoconstrictor. So if we have postpartum bleeding, we'll use it for that, or hemorrhage. And there's only about 3 indications for ergotamines. So that will help if you to remember them as migraine specific. The agents that are most effective at relieving pain and associated symptoms. So these are your mainstays. Initial treatment strategy. So it's based on their disability and severity. So let's walk through each of these. Use a non-specific agent for the milder symptoms. Reserve migraine specific for more acute attacks. Their side effect profile is so much higher. As people get older, you're going to run into trouble with the vasoconstrictive nature of the drugs. Pre-treat with antiemetic agents or use a non-oral route if you need to. Remember the suppositories. There's a nasal spray I'll show you as we go through, and injections you know about. So nausea and vomiting can affect the absorption efficacy of orally and other orally administered medicines. So there's a dual advantage there. One, to make the patient feel more comfortable. The other is that so your drugs can be effective. To avoid increasing headache frequency and drug consumption, limit the use of acute migraine therapies to fewer than 10 days a month. That's an important one. And as you're moving that patient and trying to reduce the number of attacks in a period of time, like a month, then that will be one of your goals. Or maybe the reason why you would go to prophylactic. If they're having, I've never seen, usually what the physicians I've worked with, if they're having more than 1 attack a month, they move them to prophylactic. But I don't know if that threshold is used by everybody. Okay, so preventive management on the top of page 7. So this is the prophylactic therapy administered on a daily basis. So the other are specific to an attack. So the goal there is reduce the frequency, severity, and duration of attack and improve responsiveness when they do have a migraine. So consider it in these settings. Patient has experienced recurring migraines with significant disability despite acute therapy. Frequent attacks are occurring more than twice per week with the risk of developing medication overuse headaches. Symptomatic therapies are ineffective or contraindication and produce serious side effects. Or you have an uncommon migraine variant. We'll talk about just a couple of those. Or the risk of permanent neurologic injury, or patient preference to limit the number of attacks. Comments there? Are those of you who have migraines on preventive therapy? Anybody? Mariah, no? Dylan, no?
I was,
You were. Used a beta blocker, did it? What was your experience?
It just made me super sleepy and
Yes.
tired, so I stopped it.
It's fatiguing.
Yeah.
Okay, Jordan? Nope. All right. Okay, so medications that are FDA approved for migraine prevention. Propranolol, again, it's cheap, it's been around a long time, great safety record, but it does have decreases exercise tolerance. Younger people tend to have more side effects and will notice the slowdown more in the complaints, just like Kayla has described. Timolol is also a beta blocker. It's been around a long time. It's generic. It's cheap. Propranolol, very cheap. Divalproex is Depakote. It's an anticonvulsant. Has more of a problem, so you've seen that the preponderance is women. And so this drug has the risk of congenital anomalies. So remember we talked about taking high folic acid doses to prevent neural tube defects? That's one of these drugs. You'll have to be more careful when using it. The other is topiramate. Topiramate's really an interesting drug. It's a anticonvulsant, but it has lots of other uses, and it works well with migraines. It also has some weight loss action with it, and so the FDA, they have sought a weight loss indication. I don't know that has been granted yet. But it does have some side effects that are annoying, so we'll talk about that as well. Therapeutic principles for migraine prevention. Okay. So start with the lowest dose of the medication and titrate upwards until you achieve a therapeutic effect or side effect tolerance is reached. That is almost universal when you are doing drugs, is you start with the lowest and you move up. One of the few exceptions is our steroids, where we start high and move down. So this is something you're used to with other doses of diseases. Migraine prophylactic doses are usually lower than the medication dose. So some of the like if we use a triptan for preventive, then we would use a lower dose than we would use when we do an abortive therapy. Make sense? Overuse of rescue or acute treatment will decrease the effectiveness of the preventive, so keep that in mind. We leave usually, or at least in my experience as well, is we leave them on prophylactic for at least a year, is what we did. Before we would taper them off or give a trial of lower dose or just take them off. It's common for patients to experience less frequent, less severe attacks after reducing or discontinuing prophylactic treatment. So it's kind of like it resets the brain. I don't know if that's true. I don't know how that comes about, but it's a benefit. Okay, comments on or about preventive? Okay, let's look on page 8 about rescue. Okay, we'll go down through triptans because that's a long section, and then we'll take a break. So pharmacologic management of an acute attack. So that was prevention. Now we're talking about actual treatment. So first line for mild to moderate are your analgesics. So aspirin, non-steroidals would be what you would use. They do make them in non-oral routes if the patient is too nauseated to take it. Avoid using products with butalbital. So butalbital is a short-acting barbiturate. It was around forever. It went under and it still is manufactured under the name Fiorinol. Huge drug, lots of prescriptions written for it. It's a C3. So I don't know for PAs what your laws are about C3s. Is that still under your ability to write? Yes? Okay. So it's a C3. It is prone to misuse. It's almost always in combination with Tylenol or aspirin. So it's usually a combination product. It does produce withdrawal symptoms. I would say there is no reason for you, if you see a new person, to ever use it. But I bet you will get some older patients who have been on it because it's just too frequently used. Non-steroidals prevent the inflammation. You know that. You know they're anti-inflammatories. And their action is still going to be prostaglandin inhibition. Okay, so So the analgesics, Tylenol is probably less effective, usually, and can be used in combination with others. We talked about that with aspirin, a little bit more effective. There's your Excedrin migraine. Tylenol 250, a low dose, aspirin 250, still fairly low dose, and caffeine 65 milligrams. So 2 tablets at onset and every 6 hours. I don't know why that combination works. If I can't get my headaches under control with a non-steroidal, that is usually the next thing I go to, and they usually then will go away. I don't know what it is. Maybe it's just the fact that I see Excedrin migraine on there and I know helps on the way. I don't know if it's a placebo effect or not. So the aspirin there is 500 to 1,000. Remember, aspirin is just hard on the stomach, so you need to take precautions, or a lot of use will lead to more side effects. So be careful with that one. You see max daily dose of 4 grams. And there's your ibuprofen and naproxen I put down because those are the most commonly used and recommended in migraines. I don't know that any of the others would not work as well. Comments on those? Okay. Let's talk about the ergo-alkaloids. These are interesting drugs. From a pharmacist standpoint, I think they're fascinating. They are mycotoxins, so they're fungus. They were derived from fungus. They usually infect crops, so wheat, grains, and it's probably one of the oldest toxins known that is related to food intake. So in the past, it's thought that the Salem witch trials may have been affected by the ingestion of these ergo-alkaloids because they produce symptoms that, that people would attribute probably to evil spirits. So it feels like you're on fire. It feels like there's insects crawling all over you and biting you. It is lysergic acid, so it's the foundation of LSD. Y'all know LSD? I know you didn't live through the 60s, so psychedelic, psychiatric type of effects. So they think some of outbreaks where there were more psychic outbreaks in a population may have been from the people eating these grains that were infected. Isn't that fascinating? St. Anthony's fire, not at St. Elmo's, but St. Anthony's fire is attributed to the ingestion of these ergo-alkaloids. So that's why they're very effective, but they're limited in use. Can't use them all the time, but they're very good when you do use them. So the ergotamine tartrate comes as a tablet, sublingual tablet, and also a rectal suppository. So, and usually Capergot is with caffeine, enhances its action. You see the dose written down there, 2 milligrams at onset, and then 1 to 2 milligrams every 30 minutes is needed. You don't have to know that dosing, but look at how they're dosing it to get an idea of what that looks like. It does have a maximum dose on it because of the side effects. It will make you throw up, so using an antiemetic before would be helpful. Ergamar is the sublingual tablet. I don't have any experience with that, but it's available, and then the Capergot rectal suppository can also be used. The dihydroergotamine is another ergo-alkaloid, but it is not as effective as ergotamine. So, but it's available if the patient can't use the other. It does come IV, the other one does not. So it's parenteral. And then you have Migranol, which is the nasal spray. So you've got multiple ways to get the drug into the patient, especially if they are vomiting and can't take it by mouth. So these are for mild or moderate to severe. Okay, so they are non-selective serotonin agonists. We'll see that the triptans are a little bit more specific. So they decrease inflammation and also are vasoconstrictors. Nausea and vomiting is due to the central action on the chemotactic zone. So that's where we talked about pre-treating with an antiemetic. Other side effects, the problem with these is that they get worse than the diarrhea that the person may already be experiencing, and chest pain because of the vasoconstrictors. Be careful in your older patients when considering these. That next, it's in red, but if you're not online, you wouldn't be able to see it, but do not use triptans and ergotamines within 24 hours of each other. I can guarantee you that will probably come up somewhere. You've got to remember that one. It's a extreme interaction. Strictly observe the dosing. So know those dosing limits. Know that there is a dosing limit for ergotamines. Contraindications, so look at these. So renal or hepatic failure. The next one's probably more practical. Coronary, cerebral, or peripheral vascular disease. So if they have vascular disease, you're going to have to be careful with the triptans and the ergotamines. Sepsis, pregnancy, I think that you can use these in pregnancy, but I think it's an extreme limitation for them, for migraines during pregnancy. Okay. Comments about those? Sorry, I've done so much reading. I apologize. Okay, let's take a break and we'll come back and talk about the triptans on page 9.